All right. Glad we all had some. Those cookies looked amazing, so hopefully we've got a little sugar charge. So we're going to work now through MCRPC and think a little bit about treatment sequencing and future directions. And so this is, some of the data, again, we'll be re-reviewing, but I think the goal here is to think about comparative data that helps us understand when we might use this first and that second, which in prostate cancer at this point in time, we actually don't have a ton of that. And so we kind of use those factors that I listed before, which probably are included in this talk too, and we'll review them again. So these are my disclosures. They have remained stable through the break. All right, so general principles, we went through this in detail, but these clinical factors are still key, and we won't go through them again, but just to reiterate that a novel mechanism of action is usually preferred, and this is because we want to kind of get around those resistance mechanisms that may have developed. And as we continue to see this very complex figure, I'll just reiterate again that if you are using a lot of these systemic therapies, this can be overwhelming because it is simply a list of a lot of different treatment options, but it also can help you organize a little bit because each of these boxes helps us understand where a patient has been and where they might be going. Again, the top two boxes perhaps being most relevant for urologists because these are the patients who have not been exposed to prior docetaxel chemotherapy. So to blow that one out a little bit, a prior ADT alone, our main options here are to add an AR pathway inhibitor as we're kind of sequencing through this, to add chemotherapy, consider a PARP inhibitor as we heard, but these are going to be the main options here in this first line MCRPC setting. I think we might also consider, we could use, as I said, or as is listed, a PARP inhibitor plus or minus an AR pathway inhibitor. And I did just show you the piece 3 data, so we might add enzalutamide. If we're using enzalutamide, we might add radium-223 to this as well. And that is, that's not a label, it's not added to the label, but this new data, these are both approved agents, we might be able to get them in our clinics. To blow out the progression on novel hormonal therapy after patients have had ADT and an ARPI, our options include, of course, chemotherapy, PARP inhibitor for HRR mutations, so this is going to be generally a single agent PARP inhibitor unless we think that perhaps we're going to switch that AR pathway inhibitor and use a different combination, one in combination here in MCRPC, or perhaps we'll continue our AR pathway inhibitor and add on our PARP, but that's not necessarily per guidelines here. Radium-223 also listed here, and CYP-T. And I also called out a special little asterisk just to say, and I alluded to this before, evidence really suggests that switching an AR pathway inhibitor as an only strategy is really expected to be of limited to no benefit because the resistance mechanisms that evolve to an AR pathway inhibitor are generally going to be carried through such that they will also make that patient resistant to the next AR pathway inhibitor. So we have heard about genetic testing quite a lot, so I will breeze through this, but genetic testing should be offered to all MCRPC patients. If you see a patient who has MCRPC in its late line and they haven't had genetic testing, they should get genetic testing. It's never too late to get this information. Again, germline genetic testing being really important for family implications so that people can understand if their family, brothers, sisters, children should potentially be tested for these alterations and treatment implications as well, and somatic testing to potentially catch alterations as well. And the NCCN guidelines are also in agreement here. Patients with metastatic disease should be tested. So if germline testing has not yet been completed, by the time we get to MCRPC, complete that. If somatic testing has not been completed, by the time we get to MCRPC, complete it. And we have heard about this, just the frequency that we will find these mutations, somewhere around 20 to 25%, maybe even in some MCRPC populations, I would say approaching 30%, especially if they're heavily pretreated. This table, though, just to kind of put it out in very stark terms, I think it's important for us to remember that about half of the time we will find information on a germline test, and about half of the time we will find information on a somatic test. And we've talked before about the concordance and potential lack thereof in some settings. 80% concordance is not 100%. So what we need to do for patients is to ensure that we have all of the options laid out on the table. So if we look BRCA2 mutations, about half of them are identified identified in somatic testing. About half of them are identified in germline testing. If we look at MSH2 and 6, I just want to call our attention to that. This is going to be a mutation that will enable a patient to get pembrolizumab. We always talk about MSI high status or deficient mismatch repair, high TMB. Those are general approximations for whether a patient is going to respond to pembrolizumab. They will give the patient access to pembrolizumab, but they're only general approximations to how likely a patient actually is to benefit from pembrolizumab. If they have an MSH2 or 6 mutation, they are highly likely to respond to pembrolizumab. So the genetic testing here is really important, and this was added to the label too. It says, I think, DNA repair, not DNA repair, genetic mutations that predispose someone to Lynch syndrome, which is what this is. These are going to be the mutations that we can target with pembrolizumab. MLH1 is another one, PMS2 is another one. So think about these mutations as well, because pembrolizumab can be highly effective, but most effective if we actually have the genetics that cause that response. PALB2 I'll also call our attention to. Some people think about this as being second best in terms of response to PARP after BRCA2, and PALB2 is found most often in somatic testing. So really just important for us to recognize germline and somatic, both important, and we can find different frequencies of these mutations with these different tests, and we have to make sure, though, that we do test for it. We know that there are many agents that we can consider, and this is a summary that was put together to try to, again, give us some idea of sequencing. What's important here, from my perspective, is that it only has the single agent PARPs, not the combinations that Kristen or Dr. Scarpato mentioned. It also doesn't have lutetium-177 PSMA-617, also called Pluvicto, which has taken this whole sequence by storm. So it's evolved rapidly. So let's get to some of the basic information that we have on sequencing, so we have the evidence to support some of the comments that I've already made, so you don't think I'm just making things up as I go along. So CARD was one of the very first studies that we had that looked at the use of one agent after another agent and compared the alternatives in a sequencing type strategy. And it was really, I think, quite important for us to do this study. The study included patients with mCRPC who had already had exposure to docetaxel chemotherapy and also to an AR pathway inhibitor. And what the investigators did was said if they responded to that AR pathway inhibitor for 12 months or less, they can enroll in this trial, and we're going to randomize them to receive cabazitaxel, which is that second-line chemotherapy, or the alternate AR pathway inhibitor. And remember, these were not people who had been on AR pathway inhibitors for years and years, so perhaps they were less susceptible to treatment with them, but they did have, on average, about 12 months of response to those ARPIs before they were included on this trial. And that this trial demonstrated quite clearly that the second AR pathway inhibitor, not so helpful, with a median radiographic progression-free survival of just over 3 months. So that's basically time to next scan. And cabazitaxel was substantially more beneficial to these patients and gave those patients a radiographic progression-free survival advantage with an rPFS of 8 months. I think what is also important here is that almost 70% of these patients actually had symptomatic progression before they were enrolled, so it was potentially a sicker patient population, but they were able to tolerate chemotherapy and get some benefit. Also importantly, I think we heard before that medical oncologists are very, very focused on overall survival, as we all are, I think, as doctors. But overall survival was also improved with cabazitaxel as compared to that second AR-targeted agent. So really here, not just a progression-free survival benefit for people, they lived longer as well. Also importantly, as we're considering sequencing, we have to think about efficacy, but we also have to think about safety and toxicity, tolerability, because we're not curing mCRPC. We have to recognize that we are always making trade-offs, trying to have the best balance of disease control and toxicity. Here we can see a comparison of the adverse events for cabazitaxel versus that second AR-targeted agent, and it was actually quite similar when it comes to serious adverse events between both arms. We might think that chemotherapy would cause many more adverse events than an AR pathway inhibitor, and it was not the case. Also, there was a higher risk of adverse events causing death in patients receiving the second AR pathway inhibitor, not in chemotherapy. So chemotherapy was not causing excess death due to toxicity, which is really important. The other piece, as I mentioned, is tolerability. How are the patients feeling? How are they tolerating the treatments that we're giving them? This slide is a summary of some of the patient-reported outcomes from this study, which suggests that there's a much higher proportion of patients who have some improvement in their symptoms. That's what we see on the left-hand side when they're treated with cabazitaxel, as compared to that alternate AR pathway inhibitor, and the probability of not having pain was also higher in patients treated with chemotherapy. So when we think about choosing in a sequence, particularly in a patient who's somewhat symptomatic, I think chemotherapy as this next line treatment is a smart one. Additionally, the time to symptomatic skeletal event was also longer with chemotherapy here than the second AR pathway inhibitor. And patients actually reported that their overall quality of life was superior on chemotherapy than on the second AR pathway inhibitor, probably because better cancer control in many ways equates to better quality of life. So what these scribbles mean is that the blue line is showing better quality of life higher up on the y-axis than the yellow-white line, and the blue line represents patients' report of their quality of life when they're treated with chemotherapy, and the white line is when they have that second AR pathway inhibitor. And their pain was also, as we talked before, better controlled, and that's the patient-reported outcome on the right. All right, so we talked a little bit before about histology and about the need to make sure that we are not dealing with neuroendocrine or small cell differentiated cancer, especially as we get into the later lines of mCRPC, because the more treatments that patients are exposed to, the more likely that the cancer may evolve a mechanism of resistance that ends up potentially putting that cancer into a dedifferentiated small cell type of behavior. I think the reason that we need to consider a biopsy is because the diagnosis of small cell is still made on histology. It's made by the pathologist looking at the slide under the microscope. It is not just a blood test that we can test for at this point in time, at least. When do we consider doing a biopsy? When is it worth it? Because no patient wants to do a biopsy unless it's worth it. Liver metastasis, number one reason probably. If we have really bulky lymph nodes, and one of the reasons is usually they're then easy to access and they're easy to process, so we should be able to get histology. We should also be able to get next generation sequencing and make sure we get our genetic testing done if that's of value in this time point. Also, if we see a disconnect between the PSA level and the burden of cancer. When we have a low PSA and a lot of cancer, we definitely think that maybe this is not a tumor that's being driven by the testosterone pathway, because typically testosterone activates receptors, those androgen receptors, which go into the nucleus and express the androgen response element portions of the DNA. And that testosterone and causing the ARE to be expressed is what produces PSA. So if we have low PSA, we probably have low testosterone signaling. And so this raises the likelihood that we have a small cell differentiated or non-androgen dependent type histology. We also have listed here predominantly lytic rather than blastic bone metastases, but in general, if there's a disconnect, if the cancer is not representative by what you're seeing in the imaging or the patient's quality of life or clinical symptoms, it's always wise if you have the opportunity to get a biopsy. So let's think about neuroendocrine or small cell prostate cancer. It's rare at diagnosis, though we've probably all seen it. It can arise in response to ADT or other mechanisms that suppress signaling through the testosterone receptor, because the cancer will figure out ways to grow despite that inhibition of the androgen receptor. Again, we talked about this being more common in settings of metastases in unusual sites, so liver, maybe brain. We also rarely can see paraneoplastic syndromes. These are more common when we have small cell differentiation, just like when someone has lung cancer and might have hypercalcemia related to that, or other paraneoplastic syndromes, including things like neurologic symptoms and other. This can be related to a neuroendocrine type or small cell differentiated prostate cancer. I think interestingly, although not necessarily something we use in practice, we can see an elevated CEA or serum neuroendocrine markers like chromogranin or synaptophysin, but these are not necessarily things that we are going to follow or use, but it's just of note. I think importantly, you can see synaptophysin in adenocarcinoma. So if you have questions or are unsure of synaptophysin expression on your adenocarcinoma, it's important to have a good relationship to talk to your pathologist to say, it says that there's some synaptophysin on this report. Is this actually neuroendocrine or small cell, or are you just telling me that there's synaptophysin, but it's still an adenocarcinoma? And I've had many conversations around that, so don't be thrown if there are some neuroendocrine type markers like synaptophysin in your adenocarcinoma. It doesn't mean it's adenocarcinoma. Confirm with your pathologist. And we also mentioned this before, but if you do have someone with small cell histology, we typically continue the androgen deprivation therapy because there can be heterogeneous disease burden in the patient, so there may still be some adenocarcinoma cells that are very responsive to testosterone, and then we would use a platinum doublet chemotherapy. So cisplatin or carboplatin, depending on the degree of metastatic disease, the age and fitness of the patient, and prior neuropathy or renal function type considerations. I think also we always are thinking about differential genomic and epigenomic structures, and so there is always work being done, including by some of my friends and colleagues, Misha Beltran and some others who have worked to try to figure this out. There's nothing that we can use clinically right now, but some of this work is leading to targeting. There are some cellular targeting therapies that are looking at DLL3 as an example, and so there are actually drugs now approved for small cell lung that we sometimes are using off-label, and new drugs in development in clinical trials that are targeting DLL3 that are going to, I think, be of interest as we get to further and further lines of small cell and neuroendocrine differentiation. Do not worry, urologists. We medical oncologists will take on those cellular-based therapies. We will not make you put patients into the ICU and do all of that stuff, but just know that it's coming, some of them targeting DLL3. Other alterations are being evaluated. I think we've talked quite a lot today about AR alterations. We've talked about RB, P10. You can see here there's others, HRR, DNA repair pathways. So these are complex, and understanding using the sequencing information is very, very interesting. Let's think about PARP inhibitors, and really the best sequencing information I have here, because we do not have do this, then do that, then do this kind of information for PARP yet, is that Triton-3, which we heard about a little earlier, was a study of patients with mCRPC who were enrolled if they had BRCA1, BRCA2, or ATM alterations, and they were first-line mCRPC. They were randomized to receive rucaparib or an alternate, so they all had ADT plus an AR pathway inhibitor in the prior line, HSPC. They were randomized to receive either rucaparib or the alternate AR pathway inhibitor, either Enza or Abi, or docetaxel. And the important sequencing information here is that, of course, the rucaparib was better than the combination of all of them, but in the panel A, rucaparib, when directly compared to docetaxel in this setting, was clearly superior in patients with BRCA1, BRCA2, or ATM, driven predominantly by patients with BRCA2 alterations. So the only head-to-head data that we have between PARP and chemotherapy for patients with BRCA mutations clearly says if you have a BRCA mutation, try to get the PARP to them before chemotherapy. I think this is one of the most important things that came out of this trial because rucaparib is not widely available at this point in time. On the second side here, we can see rucaparib definitely beat the second AR pathway inhibitor. Not surprising. The radiographic progression-free survival was beaten there by about 8 months. And here we can see that second AR pathway inhibitor with an rPFS, 4.3 months as the median rPFS, so just after the first scan. So just more information that a second AR pathway inhibitor, and this time it wasn't people only restricted to 12 months of prior exposure. Second AR pathway inhibitor does not really work. All right, so thinking also about sequencing. How do we choose between PARP and something else? The mutations might be helpful in this decision-making process. So There was an interesting paper that came out, sort of a meta-analysis by the FDA that looked at these differential activities of combinations of PARP inhibitors and AR pathway inhibitors across the different mutations. We can see that the combination seemed to have an improved radiographic progression-free survival that was clear in patients with BRCA1 and BRCA2, an improved overall survival very clearly demonstrated for BRCA2 mutations, still immature data for BRCA1, but when we think about the other alterations, we also have some information. Again, a meta-analysis pulling together all of these studies could give us higher numbers of these mutations, which tend to be rare and are not going to be definitively understood in any single study. And actually, even in a meta-analysis, it's not definitive. But what we do see is that PALB2 and CDK12 do appear to have improved radiographic progression-free survival and maybe overall survival, but this data is still immature. No benefit seen in treatment of these patients with ATM or if they have CHEK2 mutations, again, I think to be explored. Clonal hematopoiesis for ctDNA also is something we have to remember. And the reason this is important is because if we do ctDNA and we have an ATM alteration coming up on ctDNA, that's very commonly a false positive, a false ATM. ATM doesn't seem to respond to PARPs very well anyway, so perhaps it's really true, but doesn't really matter in terms of our clinical decision making. But because ATM is such a big gene, it's commonly going to be affected by this clonal hematopoiesis, making it look falsely positive on these assays. It says here continued inclusion of ATM for olaparib approval may change. I don't know that the label is actually going to change, to be honest, but I think that our use of olaparib for patients with ATM we may be less enthusiastic. Maybe we save that for a later line of treatment after time and use other agents earlier on with ATM mutations. So we did talk a little bit about pembrolizumab multiple times. Those genes, I just want you to remember those genes, PMS2, MLH1, MSH2, MSH6. These are Lynch syndrome genes. They are some of the most responsive to treatment with pembrolizumab, even more selective for people who might respond than high TMB, which doesn't really seem to work in prostate cancer in truth. And this rapid autopsy system found, again, we heard this already, 11.7%, and we saw a lot of these mutations here as well. So about 2.7% had these special genes that I'm just talking about. Okay, let's get into radiopharmaceuticals because the day's getting long and we need something bright to look forward to. That was a joke. All right, so VISION is the phase 3 study that led to approval of lutetium-177 PSMA-617, which is quite a mouthful, so I may call it Pluvicto. We're not generally using brand names in here, but because of my exhaustion, we might have to for the rest of the day. So this study included patients with CRPC who had previously had progression of disease on an AR pathway inhibitor and chemotherapy. So these were considered heavily pretreated patients who did not have many alternatives for therapy, at least by the assessment of the treating physician and the patient. Patients were enrolled and randomized in a 2-to-1 fashion to receive Pluvicto plus the best supportive or standard of care treatment option versus best supportive or standard of care treatment on its own. Now, in patients who have already had an AR pathway inhibitor, we have discussed that commonly these studies have been designed around the alternate AR pathway inhibitor being considered a standard of care. And so for many patients, that alternate AR pathway inhibitor was the best supportive or standard of care. This was an important option in this study because there had to be a combination for patients in the treatment arm with Pluvicto. And so there had to be reasonable safety data that this was going to be possible. And things like chemotherapy, so cabazitaxel, radium, did not have safety data with Pluvicto, and so they could not have been included as the control alternate option here. So basically, a majority of patients had the alternate AR pathway inhibitor. Some patients had already had both AR pathway inhibitors approved in the CRPC setting, including some of the patients I had that I put on this trial. And so they received things like prednisone as their best supportive or standard of care, or a bone health agent, and pain medicines as their best supportive standard of care. So keep this in mind. It's important to know what the control arm is. It was not necessarily the strongest control arm. But at the end of the day, these patients unfortunately did not have anything to be a stronger control arm, because if they were eligible for cabazitaxel or for radium, they should have already had it, not enrolled on this trial. All right, so the primary endpoint here was alternate primary endpoints of overall survival or radiographic progression-free survival, and hands down, Pluvicto beat the standard of care arm. So Pluvicto in combination with the standard of care beat the standard of care alone. This was true in both overall survival and radiographic progression-free survival. And if you read the study, you may find that there were some interesting analyses that had to be done on the rPFS information, and part of that was because so many patients were actually removed from this trial when they realized they did not get on the treatment arm with the Pluvicto. It was a really hard trial to do. There was so much enthusiasm for people wanting to get this drug that they withdrew from the trial if they couldn't get it in many cases, especially early on in the study until warning letters and different conversations were had to try to improve the fidelity there. In any event, safety data here suggests that some of the biggest things that we have to think about when we're using things like Pluvicto are cytopenias. We can see here pulled out anemia, thrombocytopenia. Obviously, these CBCs do need to be watched, and patients can have severe bone marrow dysfunction. Not especially common, but it can happen, similar to radium. So it does have to be something that we test for over time. Patients can also get fatigue, as well as some GI symptoms, and dry mouth, because PSMA is expressed in the salivary and lacrimal glands, and you will radiate these areas just as much as you're radiating prostate cancer cells, causing this particular toxicity. I think it's important also, again, if we're thinking about what are we sequencing, we have to know the quality of life data, not just the efficacy data. So here we can see that patients treated with Pluvicto had a superior quality of life by the FACT-P, which is an overall quality of life metric, as well as the pain intensity score, another patient-reported outcome measure on the right. So they had better pain control, and they had better overall functioning and quality of life. Now, when we think about sequencing with radiopharmaceuticals, therapy is one of the best approximations of should we use this or should we use that kind of a study. This study was performed in Australia and New Zealand through their cooperative group. It is a phase 2 study. It is not a study that is meant to be a registration trial or something that is truly going to be able to show us overall survival definitively in terms of the differences, because it is a phase 2 and that was not the primary endpoint. So just want to put that out there as we start. But it included patients with CRPC who had had prior docetaxel exposure. About 90% of patients also had prior ARPI exposure, but not everybody. And they were randomized to receive cabazitaxel, second-line chemotherapy, versus lutetium PSMA 617, also called Pluvicto. In order to get into this trial, and I did not say this for VISION, all patients in the VISION trial had to meet criteria as having sufficient PSMA exposure, expression on their PET scan. In therapy, they had to have a PSMA PET that showed sufficient uptake and expression, and they also had to have an FDG PET that didn't show a large amount of discordance. So there had to be essentially concordance between the two, or else not a lot of uptake on the FDG. If there were large areas of uptake on the FDG PET that they did not see on the PSMA PET, that meant there were large areas of prostate cancer that did not express PSMA, which is the target of Pluvicto, and so if you don't express it, you're not expecting that the medicine's going to get to that area. So in this study, again, they used both a PSMA PET and an FDG PET, and enrolled only people who had that, did not have a large amount of discordance. So they excluded somewhere around 30% of patients who screened to get into this study. It was about 15% in VISION. So you can see if you're using both of these strategies, you will exclude more people. In any event, the primary endpoint here is actually PSA response rate, and they had multiple secondary endpoints. But the goal here is to understand, do I use chemo next or do I use lutetium next? And so a sequencing question, it's very important. Here we can see that there was a better PSA 50 response for patients treated with Pluvicto, which is the right-hand side waterfall plot showing lines going down, PSAs going down. On the left, you can see the waterfall plot for cabazitaxel, that chemotherapy. Fewer lines going down means less of a PSA response. Here we can see the radiographic progression-free survival that does come out to be superior for Pluvicto as compared to cabazitaxel here. Hazard ratio 0.63, so it's able to prolong the time to progression as compared to chemotherapy. They also did this deterioration-free survival analysis, which is a composite of cancer control and patient quality of life. The way that you kind of fall off on this particular curve is that either you have a progression event or you have a decline in your quality of life. And so lutetium PSMA 617 Pluvicto was able to maintain disease control and quality of life for longer than cabazitaxel. Also importantly, there was similar overall survival between these two agents, which I think gives us hope in our clinic that if we don't have access to one or to the other, we can actually do pretty well. We'll just give the other one next. And so this was overlapping curves. Remember, I said it's a phase 2. This was not a primary endpoint, but it does, I think, especially when there was a Pluvicto shortage, this gave me a lot of hope that we could get it in later and not lose a lot of ground. Also importantly, when we think about making decisions in sequencing, we have to understand, is one of these going to be more effective than the other, one of these treatment options? When we think about Pluvicto, obviously we're going to be selecting patients who have a PSMA PET that shows significant uptake and expression on that scan. SUV mean is basically a composite of all of the brightness of the PSMA expression. They just average it across all of the areas of uptake. It is not commonly given to us in our clinical scans. You have to either ask for it, you may not get it. It's really a research type of a construct that we're working to in clinical practice. But the reason this is important, it's different than an SUV max that we've been using on other types of PETs for years. The reason that it's important is that it does seem to be associated with response to Pluvicto. So if you have an SUV mean that is greater than 10, which is the blue line, you're going to have the longest time to progression. You've got the brightest overall disease burden, and so you might have the best response to something that's going to target that disease. Whereas if you have the lowest expression of SUV mean, you're going to have the least time to progression. So all of the patients in this arm as a group seemed to benefit. So this is not to say that these patients didn't benefit, it's just the degree of benefit. And when we're looking at chemotherapy versus looking at Pluvicto, there might be a time that we say, okay, well this patient has an SUV mean of 15, so I'm definitely going to choose Pluvicto, but this person has an SUV mean of 5, so maybe I'll choose chemotherapy and I'll use Pluvicto later. So we're not necessarily using it now, but I can imagine this coming into our algorithms in the future. And so I also wanted to just share, as I mentioned, we now have an approval about 2.5 weeks ago of Pluvicto before chemotherapy. So we went through all of the post-ARPI, post-chemo information, but there's also the PSMA-4 trial, which is not in here in high amounts because we just got this information a few days ago or a few weeks ago, and these slides went in a long time ago. But this is the survival curve from PSMA-4. This was a patient population with CRPC who had all had exposure to ADT and AR pathway inhibitor, had not been exposed to chemotherapy. The randomization was between the alternate AR pathway inhibitor, not a great control arm, and Pluvicto. And we found that Pluvicto prolonged the time to radiographic progression-free survival as compared to the alternate AR pathway inhibitor, which we know is not the greatest control arm anyway. But then the overall survival data suggests that there is a hazard ratio of 0.98. We see the curves pretty much overlapping. Some patients probably benefiting a lot, some patients maybe benefiting less, but we now have the opportunity, if we want to use Pluvicto before docetaxel chemotherapy based on this approval that just came out. And this study is what supported that it seems safe and is now an option for patients. And then we can go on to chemotherapy and all of the other things that we want to use. So, thank you for your attention. There are 5 classes of FDA-approved therapies that improve survival for men with CRPC. Sequencing of the AR pathway inhibitors is expected to have poor to no response, so please try to think of something else. Lutetium PSMA 617 is now FDA approved. We actually can now use it. This is updated before chemo if we want. We can also use it after chemo. Cabazitaxel, we usually dose at 20, not at 25, for what that's worth. Platinum doublet chemo can be considered for neuroendocrine patients, and future treatment strategies are definitely going to be including our PARP combinations. We might use bispecific antibodies. There are so many things that are coming down the pipeline, so get ready and get excited because it is definitely a changing landscape that has lots of opportunities for our patients. So thank you.